My name is Russ Derry, and I'm the Director of Education for Epilepsy Foundation of Michigan. And our Learn and Share conference call this evening is Seizure Types and Classifications. And we're happy to have with us Dr. Erica Austin, who's an epileptologist practicing in Traverse City, Michigan. So Dr. Austin, welcome, and can you please just introduce yourself briefly and share a little bit about your clinical and research interests?
Sure. Hi. I always want to thank everyone for joining. I know that seizure types and classification isn't the sexiest topic, and I think that it's great that everyone's interested in learning about this because it can be a little dry, but it's an important thing to kind of further everyone's education, and I kind of want to applaud everyone for having the interest and learning about this thing. As Russ mentioned, I'm an epileptologist and a general neurologist as well. I practice in Traverse City. I did my training at Michigan State for both residency and fellowship, and I worked at Michigan State for a few years before moving up here. And I don't currently do any research in Traverse City. We did some at Michigan State, but clinically, really trying to bring high-level epilepsy care to the northern Michigan region where we didn't have people with epilepsy knowledge as much as the other areas of the state. So that's kind of my clinical goal.
Great. So before we get into detailed discussions about each seizure type, can you talk about why it's important in making a diagnosis to correctly identify what type or types of seizures a patient is having, and then why it's important for the patient and family to understand this information as well?
Yeah. I mean, most importantly, I think that we were looking at that medication can vary some. So, you want to make sure that we're selecting the appropriate medication for the seizure type the patient has. It's also important when we're looking at research, classification of the seizures, when we're looking at treatment options outside of medication. So if someone needs treatment options outside of medication, the seizure type makes a difference. It's important for communicating with the doctors, and so knowing, and with others, kind of knowing what kind of seizures you have and how to describe them and how to kind of make them clear can really help facilitate kind of your care and making sure that all of your providers have a good understanding of what's going on.
Right. So roughly how often are you able to confidently determine the patient's seizure types based on the description of the symptoms alone? And if you can't, then what are the next steps to try and get at that diagnosis?
Yeah, I would say it depends on the description. So this is where this education is really important. So this is where the patient and the family, especially kind of the people who have watched the seizure, but even the patient in their description of things, but knowing kind of how a seizure starts and the first part of a seizure is often one of the most important things of classifying it, and we're going to kind of get into that further when we're looking at focal and generalized and things like that. But knowing how it starts is one of the most important things, and the progression is important as well. But so it depends on the ability of the observers, how much of the seizure they've seen, how much they remember. I mean, seizures can be pretty traumatic events. They've never seen one before, so it's hard for the observer to sometimes remember well. So I would say the accuracy of that depends a lot on what the witness is able to describe. Then also there's information that can help us more. So certain ages are important. There are certain types of seizures that happen in children as one or two types. If they happen in adults, then we think, well, that's more likely to be this. For example, a new onset seizure that appeared to be generalized, that had shaking of all four limbs in an older patient, say, in their 60s or 70s, is more likely to be actually a focal seizure that then quickly went to be a general seizure, simply because they would have had a generalized seizure earlier had they always had this tendency. So the age can be important in deciding that. And again, just like I said, the seizure type. So if we're looking at age and seizure type along with description, that will give us clues that will help us be better. And then obviously the EEG is very important. So getting an EEG that shows us a focal area of irritability, that tells us that at least some of the seizures come from a focal area. Whereas if we get an EEG that clearly shows a generalized seizure tendency, then that gives us that information. So the EEG is paramount, is really important when we're looking at this classification as well.
Okay, and then if a routine EEG and the description that you get from family members and the patient is not sufficient to figure out what type of seizure, then presumably the next step is video EEG monitoring if available?
Yeah, for sure. So, especially if a routine EEG is normal and we say, gosh, the routine EEG is normal, I'm not really sure what type of seizures or type of epilepsy you have, I think that you'd be best served by actually having a video EEG, going into a monitoring unit, trying to capture the seizure so that we can get a really clear description of what it is. The fancy word for that is semiology, so we can see exactly what happens. And then we get the bonus, rather than just seeing, say, a video, we have the EEG, and we can see how those things match up. So we can see how the activity in the brain match with the physical manifestations, the presentation of the seizure. And that's really, an important part of diagnosis. That's where the monitoring units are really important.
Great, great. So how does your determination of a patient's suspected seizure types influence the treatment you select? And you alluded to this a little earlier, but can you talk a little more detail about that?
Yeah, so we want to pick the right medication. So kind of the, when we look at, say, for example, medically intractable epilepsy, so people who have seizures that haven't been able to be controlled with medicine, the definition of that is 2 or more appropriately selected and adequately dosed. So they're saying, well, you have to pick the right one for this to be an adequate trial. We want to treat the patients best we can. So knowing the seizure types can help with that. And there are some medications that can even cause more seizures in patients that are given the wrong type of medication. So that's important. And then, as I kind of mentioned earlier, when you're looking at non-medical treatments, the seizure type makes some difference as well.
Right. So how often do you have patients referred to you who are on an inappropriate medication because their seizure type has been improperly identified? And can you give a couple of examples?
Yeah, I've actually had a couple examples in the last, 6 months or so from my own practice. And the biggest one is carbamazepine, which is also known as Tegretol. It's a medicine that can worsen some of the generalized seizures, so like myoclonic, juvenile myoclonic epilepsy and things. It can worsen those seizures. I had a patient who was in her had been on carbamazepine for a long time and said, she no longer had generalized tonic-clonic seizures. She never had them, but she still had what she called her small seizures, which were seizures where she'd have impairment of her awareness. She'd miss some time. They often happened at night. And she was still having these, 1 to 2 times a month. So she was still having a lot of these, and she had been for years. She said, that's just, I know that's the best we can do. And it took a lot of convincing to tell her, listen, I think this medicine is what the issue is, and if we can get you off of this, we may get you to have no seizures. And since she had been on it and she hadn't had a generalized tonic-clonic seizure, a big seizure for so long, she was very hesitant because she was worried that she would. But we went through that, and she's no longer having those seizures off the carbamazepine and on a more appropriate medication.
Great. Okay, so now let's talk about the different seizure types. To clarify, the International League Against Epilepsy created a new classification of seizure types in 2016 and then further revised it in 2017. And many of the newer terms may not yet have caught on in the public or even in the medical community. But because people are likely to hear both the newer and older terms, today we'll try and use both whenever possible, starting with the newest term and then also providing the older and probably more widely used term. So we'll start by talking about focal onset seizures. These can also be referred to as partial or localization-related seizures, but focal seizures can either be focal aware, and the older term for that, which again is still widely used, is simple partial, or focal impaired awareness, and the older term is complex partial. Again, both of those terms, all of those terms are still widely used, and again, looking at focal aware and focal impaired awareness as the newer terms, you can also see variations of that and change the order around. So instead of saying focal aware seizure, you could say focal seizure with intact awareness, or you could say instead of focal impaired awareness seizure, you could say focal seizure with impaired awareness. So that's kind of part of this new classification system that's kind of modular, in that you can move the descriptors around a little bit depending on what information you have. But focal seizures can also be broken down into motor onset and non-motor onset. But for the sake of connecting this newer terminology to the older terminology, the complex partial and simple partial, I'm going to focus on the aware versus impaired awareness distinction. So let's start with focal aware seizures. So of all of the seizure types, focal aware, again the older term is simple partial, features the widest range of possible symptoms. Can you start by describing what all focal aware seizures have in common? And then after that, talk about examples of different symptoms that may be experienced with the different subcategories of focal aware seizures.
Sure. And so, well, as it's kind of clearly stated in the new classification, and that's kind of the goal of the new classification, is to make things as kind of practical as possible. One of the things all focal aware seizures have in common is they have awareness maintained. So that means the patient is aware of what's going on, and afterwards they might be able to tell you that that they were aware that this happened, that they heard you but didn't answer. But they're able to talk to you about that. All of them also are brief, and so they're kind of the teaching that we give the residents is, a brief stereotypic event. So it's kind of a brief event that is always the same and comes and goes. And when I talk to patients about it to see if, they've had any of these events, I typically say it's something notable, because I'll have a patient that say, had a seizure, and they say, I had this feeling like 20 years ago. Once before I had this real brief feeling, and it was notable. I only had it once, but it was the same feeling that I had just before this seizure. So it's usually something that's kind of notable. So that's kind of the big hallmarks are the awareness, and then it's real brief. The different categories are, there's a few, but motor, autonomic, behavioral arrest, cognitive, emotional, and sensory are the big ones if we look at their breakdown on there. And so motor are kind of limb shaking. They're focal, right? So we're talking about focal seizures, so it would be one limb or one side of the body perhaps that we're talking about when we talk about those motor seizures. Autonomic ones that refer to the autonomic part of our nervous system. And those are things like like stomach symptoms, like a feeling of nausea, or maybe a flushing that comes and goes. But things related to kind of regulation of temperature and things. A behavioral arrest are real brief stops of what they're doing. Lots of seizures can kind of start with a behavioral arrest. So when we call it the seizure of that type, if we say it's a non-motor focal aware seizure with behavioral arrest, it means that that's kind of the whole event. The whole event was they kind of stopped what they were doing, and you talked to them. They didn't really answer. They came right back, and then they said, yeah, I heard you say that, and they have an awareness that they had it, but they had a behavioral arrest. A cognitive one is basically problems with thinking. So it's something going on with the thinking that they have, but again, it's still an awareness of what's going on around them. Emotional focal seizures are real brief feelings that are, again, like I mentioned earlier, kind of intense. Fear is actually, unfortunately, one of the most common ones, a sudden brief feeling of fear that's unrelated to what's going on around. Anxiety can be one, too. There are people that get brief feelings of joy, so there are some happy ones. Anxiety can be one. I know I had more than one patient who had been treated for years for anxiety, yet when I talked to them about it, they'd said, describe your anxiety, describe your panic attacks that you're treated for, and they would say, well, they're real brief. They're just seconds. They just come and go, and I feel really anxious, and then they're gone. and you talk and say, well, is it when you're thinking about something that causes anxiety or in a situation? No, they just come and go. And they've actually been having these small focal seizures for a long time that no one's actually figured out were seizures. So those are the emotional seizures and focal aware. And sensory seizures, the one that I think a lot of people are aware of is an odd smell, a smell that doesn't fit with the environment, like a burning smell or a metallic smell. Odd taste can also be there. Really, any of the senses can do it, but it's, like we talked about, all focal aware seizures are brief and awareness is maintained. So it's a real brief, notable sensation, such as a smell or a taste that comes and goes. And I think that those are the big categories that they talk about.
Right, and when you mention brief, because I do often try to figure out when people are describing symptoms, is this something else or is it possibly a focal aware seizure, and someone who's describing something that lasts 5 minutes versus 10 minutes, is there a kind of an upper limit to how long these typically last?
Yeah, I mean, we're talking about less than a minute, so very brief, and oftentimes just seconds. Like, it comes and it goes, and I have patients say, gosh, it's this feeling, and it comes, but by the time I realize it, it's gone. So often, really just seconds even, but less than a minute is kind of the cutoff that I would go for.
Right, okay. So many people with epilepsy don't really consider focal aware seizures as actual seizures. They may just call them auras, particularly if they happen prior to another seizure, or they may not pay much attention to them. Why is it important to track and report focal aware seizures to your neurologist just like you would any other seizure type?
Yeah, I think that's a really important point. I think that, it's okay to call them auras as long as you realize that they're a seizure. So they're still seizures, and especially when they're beginning, like the example I gave of my patient who had remembered having that feeling 20 years before, and then she had it right before a seizure that generalized, which is the reason why she noted it. She said, I remember I had this feeling before my seizure, so she felt like the feeling wasn't the seizure. We talked about that and let her know that that feeling was a seizure, and then I needed to know if she had it, because that would help us know if her medication was working. So getting your aura, or a focal aware seizure that comes, is telling us that, you're still having a seizure. So that says we need to change the treatment plan and adjust it for that. I think that's the most important part. And it's one of the things, again, that in training we're taught, that I try to teach, that you say, we try to ask patients, well, have you had any of your aura? So we say, do you have any seizure? Well, what about that feeling? Have you had that at all? Because lots of times patients don't think to mention it. And so bringing that up is really important.
Right. Can you give a few examples of how the symptoms of a focal aware seizure can give you clues as to the location of the seizure focus?
Yeah, for sure. That's the interesting thing, is a lot of the seizures, is when they're focal, they tell us what part of the brain they're coming from. So, for example, if there is a forced head and eye turn, and someone's turning to look to a side and can't overcome that, then we know that maps to the opposite side. So it's the opposite side of the brain. If someone has a smell, that feeling we talked about, that doesn't really tell us what side it goes on, but we know that it's more associated with a type of epilepsy called mesial temporal epilepsy. If you kind of have a focal aware sensory seizure, so we'll call it with all the fancy words, a focal aware sensory seizure that is a somatosensory seizure. So somatosensory symptoms would be tingling or numbness of an arm. We know that goes to the contralateral, the opposite sensory area of the brain. So when we hear these descriptions, it gives an idea of kind of what area of the brain is having that malfunction at the time.
Okay. And what about déjà vu? That's a common focal aware seizure that people report. Does that give you clues as to the type of epilepsy or the seizure focus?
You know what? I'm not entirely sure where déjà vu localizes to. Can you answer that?
So I think I remember it being associated with temporal lobe epilepsy, but I'm not sure. And
yeah, I don't think it goes to the side though. Okay. I'm not sure if it tells us what side it's on.
Yeah, sure. But and that's another one that doesn't necessarily fit neatly into one of those categories. I think it would fall under cognitive, but it's sort of emotional at the same time too. But,
right, exactly.
Yeah. Okay, great. So unlike focal aware seizures, focal impaired awareness seizures, or again the other term is complex partial, those do impair consciousness and awareness. Can you talk about the typical features of focal impaired awareness seizures and how they can vary according to the location of the seizure focus, the age of the patient, and other factors?
Yeah, and I think that it's important to kind of realize, like we talked about with the focal aware, that awareness is an awareness of the events that happened during the seizure, not an awareness that it happened. Because there are people that can have focal seizures with impaired awareness that when they come out of it realize they've had a seizure, but they didn't have the memory, the awareness of the events during the seizure. So that's there. And it's also a little different than responsiveness, and I'm not sure if you plan to mention responsiveness later, but it's a little different from being responsive. People can have impaired awareness and still actually be responsive, maybe do things that seem sort of normal or even answer people, but they have no recollection of that afterwards. So the impaired awareness is still there. But I would say that you have to say about how they vary according to location. And so if we look at the most common places where we'll have a impaired awareness focal seizure is in the temporal lobe and the frontal lobe. And the frontal lobe tends to be shorter and more sudden. They tend to be real quick in onset and real quick in offset, kind of a big burst of something and then come back between when we look at those two. And again, the most important thing is that they just don't recall the event. There are lots of different types, and so in children we have different types than in adults, but overall the most important is that they don't recall and that it's still a focal event. There's still one part moving, not the whole body. There's not a loss of tone and a fall down. It's still kind of localized to one area.
Right. And so I guess what would be the most typical focal impaired awareness seizure, the most common presentation, I guess, or the common types of symptoms that you might see?
Yeah, I would say probably kind of the temporal lobe seizures would be the most common. In fact, I saw a patient today who was saying, well, I'm still having these seizures. She calls them her blackouts, where, and she works as a waitress, and one of the examples she said is, one of my coworkers said, well, I knew something was wrong because you were holding your money and you were looking at it, like you couldn't figure out how to count it at the end of the day, and then you just put it up on the bar, turned around, and walked out. And she had no memory of ever doing any of this. So she was able to do things and kind of did things that seemed somewhat normal, but then didn't have any memory of that. And she has an epilepsy that starts from her left temporal lobe. And I would say that the temporal lobe seizures are the most common form of kind of the focal seizures with impaired awareness.
Right. And then frontal lobe focal impaired awareness seizures can sometimes involve much more unusual behaviors that could
exactly
be
and
more misinterpreted.
Yeah,
like
the frontal lobe seizures in general, both focal and generalized, are ones that can often be misinterpreted because they, like you said, they might have just kind of an outburst of movement or behavior that are odd.
Right. Okay, so in some cases, a person's level of awareness is unclear or is in some kind of gray area between aware and impaired. For example, a person may be unresponsive and unable to understand their surroundings, but they may have some memory of the actual event. In other cases, a person may be able to respond to commands but really have no memory of the event. In either case, the level of awareness is unclear. So in such cases, would you simply leave the awareness descriptor off of the seizure classification and instead make the distinction between motor versus non-motor, or how would that work, I guess?
Yeah, exactly. I mean, you can definitely make the distinction between motor versus non-motor and focal versus generalized. The awareness and the impaired awareness in the new classification system is helpful, but it's not critical. It can be unclear, and you can leave that off and go with focal motor or generalized motor and those kind of things. But I think, as I mentioned, that the key element is if the patient can remember. And there are times when the patient can't tell us that or, isn't sure. But you're right that in responsiveness and awareness are two different things. And someone can be responsive, unaware. Someone can be unresponsive and aware. So that can get confusing, I think, for patients to kind of understand why it's called one thing. And then it's also sometimes difficult to understand which is which. But leaving that off in kind of using the classification is completely fine.
Right. And one other thing is that another key feature of the focal impaired awareness seizures is they tend to have a post-ictal period. Basically those and tonic-clonic seizures are the two that are most likely to have post-ictal periods or symptoms. So can you talk about the common post-seizure symptoms that you're likely to have with a focal impairment?
Yeah, and that's where kind of when we're talking about awareness, we're talking about awareness of events during the seizure, because someone may become to realize they're post-ictal, kind of know the feeling of being after a seizure, and say, well, I know I had a seizure, and that awareness of having a seizure isn't the kind of awareness that the classification is referring to. And lots of post-ictal symptoms can be headache is very common, nausea can be one, just kind of a fatigue, a lethargy, just kind of feeling run down, I would say, are the most common ones I hear people. Confusion, and then, although not directly post-ictal, lots of times people can feel frustrated or or even, well, sometimes the anger can be actually post-ictal, but there's times just when the realization that you did things you weren't aware of can be hard emotionally that might not be directly kind of physiologically post-ictal, but are still part of the whole process.
Right. So one of the biggest surprises to me when I read through the new classifications was the presence of focal motor seizure subcategories. So things like focal motor seizures can be classified as automatisms, atonic, clonic, epileptic spasms, hyperkinetic, myoclonic, or tonic. And a lot of those, I had always thought that tonic, myoclonic, atonic, and clonic seizures were exclusively generalized seizures. So that was certainly eye-opening to me to know that they could be focal as well. Can you briefly review the symptoms of these different focal motor subtypes and how they're distinguished from their generalized counterparts?
Sure, and I think that kind of most broadly, the words focal motor describe it. So it's a specific area. So, for example, especially when you said that you really thought myoclonic was always a generalized seizure, they can have focal areas of myoclonic, of brief, irregular jerking of a limb or the one side of the face of a specific area. So it's kind of the idea that it's a specific area. But you can also have the focal automatisms, which are they just happen to localize. They're focal because they localize to a certain area. So they might not look that focal when you see it, like lip smacking or picking up objects, things like that, can actually be focal in origin. Those are a little difficult to kind of tell by, when we talked about can you tell by the description. The focal atonic would be the sudden loss of muscle tone or strength in, say, one arm or one leg. So you have a briefly, the limb goes limp briefly. A focal clonic, again, is the rhythmic jerking of one part of the face or the body, so just a specific area. And then a focal hyperkinetic would be, shaking and stuff like that. The hyperkinetic seizures come from the frontal lobe, like we kind of talked about a little bit, right. And so that can sometimes be both sides of the body, even though it's a focal seizure. So that's where it gets confusing. They look kind of interesting anyways, where they can be mistaken for something else other than a seizure. And then when they're both sides of the body, if people are moving both sides of the body and they're still aware, it's confusing and can be thought of as something else. But that can, when we hook them up to the EEG, it can be seen as a focal in origin.
Right. And so it sounds like one of the key distinguishing factors between whether it's focal or generalized is whether both sides of the body are involved or just one side. in terms of symptoms?
Right, and then sometimes it's something that we need to see on the EEG, right. Such as kind of the automatisms or a focal autonomic seizure. It's really hard for us to figure out what that is based on a description, and so we would need to see that on an EEG to kind of figure that out a little more, like the focal cognitive, where there's a brief thought. So there's a brief impairment of language. Well, we know that language comes from one side of the brain, so that could be just a focal seizure, and the EEG would help us with that.
Right. Okay. Another important category of focal seizures is focal to bilateral tonic-clonic seizures, and the older term for that, which is still widely used, is secondarily generalized tonic-clonic seizures. So this is a tonic-clonic seizure that has focal onset. So in addition to the presence of or the possible presence of a focal aware seizure or aura prior to the tonic-clonic seizure, are there other symptoms in a tonic-clonic seizure that can help classify it as focal to bilateral as opposed to generalized onset?
For sure. I mean, as we talked about a little earlier, the description of what happens at the very beginning can be really helpful there. So if someone, and I've gotten some really great descriptions from patients' families who didn't know they were giving great descriptions, and I, said, that's great, you did the perfect job. But I had a patient a few weeks ago who they said, she always is trying to look over at something. She's always trying to look there. And I said, well, when she's trying to look there, can you bring her attention back? And, the mom said, no, I can't bring her attention back. So what's called versive head movement, which is kind of a forced turn of the head, so it can't be really overcome, of the head and the eyes. And that can help us say that this is starting in a focal spot. Or if the one arm starts shaking first, then again, we're looking for focal findings. The EEG often helps us as well. If we actually catch a seizure on the EEG, we can see that it starts in one side and either slowly or quickly spreads to both sides. Imaging can actually help too. So if we have an image that has a lesion, a spot of abnormality on the brain that we think is epileptogenic, is likely to produce seizure, then we kind of have an idea that, well, we think it starts here. And as I mentioned a little bit, age is important. So an 80-year-old is unlikely to have a new generalized onset seizure. They're much more likely to have a focal onset that then would go into a generalized seizure. And so that's the kind of thing that leads us towards thinking that.
Right. And again, that's important because it helps determine, what medications might be appropriate and what treatment options are available. Mm-hmm. Okay, so let's talk about generalized onset seizures. Let's start with the seizure that most people think about when they think about epilepsy, and that's a generalized tonic-clonic seizure. Can you describe what typically happens during this type of seizure and describe any variation in symptoms that may occur?
Yeah, for sure. So the classic seizure of a generalized tonic-clonic is kind of the parts that it means. So tonic is the stiffening and tightening phase. And so people tighten and stiff up. There's often a cry that comes out as the vocal cords tighten up. It's called the ictal cry, which is just ictal means during the event. And so it's just a cry that happens at the beginning. So the tightening and a stiffening that then moves into the clonic, which is the rhythmic jerking. As kind of the seizure activity in the brain evolves, there tends to be a decreasing frequency of the jerking. So it would be fairly fast, and it's always rhythmic, and then the frequency kind of slows down as it goes along. That's why it's important to kind of see the beginning part when we're looking at the generalized seizures and talking about what kind of generalized seizure it is. Seeing the beginning part of the seizure can be important to tell us what happened at the beginning to know which type of the generalized seizures they are.
Right. Okay. So on the opposite end of the spectrum, we have absence seizures. Can you describe what absence seizures look and feel like? I mean, personally, you can't describe what they feel like, but what patients have described them feeling like, or what it's like to realize that you've had one.
Right. So a typical absence seizure is real brief. It's it's seconds. It happens in children primarily, and the patients I've talked to have said they really just don't even notice it, but they might notice that something's past where they are. They have a hard time remembering, like keeping up with what's going on. Sometimes it's brief enough that patients can just keep up with the conversation that's going on or the lesson that's going on at school. But there's sometimes when they feel like there's gaps in things that it's hard to follow. But it's a real brief. There are times when patients have maybe some automatisms too, so they might have like some lip smacking behavior or some fumbling with the fingers. But it's real brief, and when I say real brief, again, we're talking seconds. Just kind of an on and off switch, and there's no post-ictal part. It's just kind of on and off, and there's no fatigue or confusion or what just happened kind of statement. It's just kind of a light switch going on and off. There's also atypical absence, which tend to be a little longer, and the on and off tends to be a little slower. It's more like a dimmer switch on and off, and so that's how we differentiate it. They also might have kind of more of a change in the tone of their body. They might kind of have a more of a head droop or kind of a loosening of their body that they wouldn't see in a typical one. There are a couple other less common types of absence seizures, like myoclonic absence, where the arms may have a ratchet motion where they jerk and go upward a little, as well as kind of this brief zoning out, this brief loss of awareness. And then there's sometimes called eyelid myoclonia, where they have an upward eye movement and jerking of that. The absence with eyelid myoclonia is something that we see in Jevons syndrome. I don't actually see it because I don't see children, but that other people see in that. But those are the different absence seizures that there are.
Right. And they tend to occur, particularly when they're first or before they've been diagnosed, they can occur hundreds of times throughout the day.
Mm-hmm. And often with hyperventilation, you can make them come out.
Right.
And so the first time I saw an absence seizure was as a medical student, actually, in the ER, and there was a child who would have been having hundreds of them that day, and they brought us down and asked the child to breathe real rapidly, and we were able to see, a handful of them right there in the ER because he was having so many.
Right. So I know that absence seizures are more common in children, but would you say that they're rare in adults or just less common than in children?
I would say they're less common because there are cases where absence seizures might continue on from childhood, but I would say they're not newly diagnosed in adults. And
right.
This is an older terminology that sometimes the physicians, particularly non-neurologists, will make. I see ER notes where the patient says, the patient was having episodes of lost time, and I think they have, it's a 65-year-old, I think they have absence seizures. And we know that the newly diagnosed adults don't have absence seizures.
Okay. So another generalized seizure is a myoclonic seizure, and we've mentioned focal myoclonic seizures, but can you talk about these seizures in general and in their generalized manifestation?
Yeah, so the myoclonus tends to be non-rhythmic jerking, and it can be jerking, I would say it's probably more commonly jerking of the arms. It can be jerking of the legs or jerking of the trunk. They're non-rhythmic. They can sometimes be just one jerk or a set of jerks in a row. The classic presentation of juvenile myoclonic epilepsy is arm jerks in the morning, and typically ask patients, like, well, do you feel like you're clumsy in the morning? Do you drop things or throw things across the room suddenly? Because they might be brushing their hair and have a myoclonic jerk, and the brush flies out of the room, and the patient just always thought they were clumsy, when really it's a little seizure. They can vary in location like that. They can also be associated with the other kind of generalized seizures, so they can go myoclonic with a tonic seizure as well, go into that, or myoclonic into an atonic seizure.
Right. And how do you distinguish between those and the benign myoclonus, or that jerk that a lot of people have experienced when they're falling asleep that kind of wakes them up, or they sometimes feel they're falling and then they have a jerk that wakes them up?
Right. Usually timing is the way that
right.
it's done. And you can have myoclonus from other things. People can have myoclonus from problems with their spinal cord. They can have myoclonus that just happens that we don't really have a great answer for, but we know it's not seizure. EEG is very helpful in that. The most common question is the one that you did. A lot of patients say, well, I get these jerks at night. And most of the time that's just reassurance that that's something that happens at sleep. We have fancy medical names for it even. And it's just something that happens in that sleep-wake transition where odd things can sometimes happen.
Okay, so both tonic and atonic seizures can cause sudden falls. Can you talk about each of these seizure types and how to distinguish between them?
Sure. So tonic means stiffening. So tonic is where the muscle tone increases. So you've got a stiffening of it. Patients, when they have a tonic seizure that results in fall, tend to fall backwards. If you can imagine, if you tightened your body up stiff as a board, well, most people just fall backward with that. And the atonic is the opposite. So A means, none, and so that means a sudden loss of tone. And that tends to fall forward. All of a sudden you go limp. It's a forward motion that people have. There tends to also be a quicker recovery with atonic seizures. So, for example, if there's sometimes atonic seizures that are mostly just the head, or in a patient sitting in a wheelchair, the head and the trunk, but they don't fall out of the chair. And it might just be a head nod that you don't really notice unless you were looking for it because it's so brief. It's a loss of tone and right back, whereas the tonic tend to be a longer lasting.
And is it clear whether or not there's a loss of consciousness, or is it assumed that there's at least a brief loss of consciousness during these types of seizures?
I think it's assumed there's a brief type of loss of consciousness, like similar to absence. But with the atonic ones, as I said, some of them are just literally like a snap of the fingers. The head bobs and is back up, and one's not even sure if it happened. So it's such a fraction of a second that it would be hard to even test it.
Right.
So.
And typically there's not significant post-ictal periods after either type.
Right. But because they're generalized, we assume that there's an alteration of consciousness.
Yeah. Okay. And at what point do you advise a patient who's experiencing either tonic or atonic or in some cases tonic-clonic seizures, when would you advise them to wear a helmet?
I actually asked a colleague about this today because I said, I don't know if I have a kind of practice norm. I typically, when there's not set rules and recommendations for things, try to just at least have an internal consistency. But I would say when it's clear that they're going to fall. And so if you have a patient who say is always in a wheelchair and doesn't walk, and they have a head bob, so they have an atonic seizure, and they might have them frequently, but they're strapped into their wheelchair, they don't ever go far enough down to, say, hit on their tray, they don't fall out, then they probably don't need to. But if it's clear they're going to fall and hit the ground, then we really need to protect the head to prevent, any damage from that. And so that's kind of when I think it makes sense.
Can you briefly describe the remaining generalized onset motor seizures that we haven't yet mentioned, the clonic, myoclonic, tonic-clonic, and some of the other types?
Yeah. So the nice thing about this is if you kind of get an idea of what the words are indicating, if you translate the fancy words, then we get a good idea. So the clonic are, just rhythmic, sustained jerking of the limbs or of the head. And there's no kind of initial tonic phase. A generalized clonic without any initial tonic phase is more frequent in kids than in adults. The myoclonic tonic-clonic is, again, like you said, it's important to see the beginning part, and that's the, the non-rhythmic myoclonic jerks of both sides that then result in a tonic, the tightening, and then followed by the clonic. So rhythmic sustained jerking with then what we would expect to be is a decrease in frequency over time. And the myoclonic atonic, similar. So you have the non-rhythmic jerking followed by a sudden loss of tone. And then epileptic spasms are kind of a flexion at the trunk and then either a flexion or extension of the limbs. And this is one where we kind of really need the EEG to kind of separate if it's focal versus generalized. But those are the spasms that we see in infants primarily.
Okay. So a new major category of seizures was added to the new classification, and that's unknown onset seizures. Can you briefly talk about why this category exists and the most common types of seizures that would be classified as such?
Mm-hmm. So the category exists because kind of the classification asks for an 80% certainty. So they're not saying you have to know for sure. So then it doesn't ask the patient or the doctor or anyone to know for sure, but you say, gosh, this makes most sense, and I'm 80% certain that this is it. But there are times when just kind of not sure. For example, the epileptic spasms that we talked about, it's really hard in clinical description or even watching the seizure to be sure. And if you can't get an EEG, and there are lots of places, especially worldwide, that you look at. So this is the International League Against Epilepsy. So they're trying to accommodate places with a lot of different resources. Very few EEGs in certain places in Africa and in different developing countries. So they're trying to help the researchers and the clinicians everywhere. Right. So there's lots of times when you're just not that sure. They don't know. Tonic-clonic seizures, if you see the beginning of it, you don't know if there's a focal phase. Say, for example, a new onset tonic-clonic seizure in a 20-year-old. So is there someone who's just having their first outset of a generalized seizure, a generalized epilepsy, or is it someone who has a focal lesion and they're having a focal seizure at first? It would be really hard to tell necessarily. And behavioral arrest is another one, like the epileptic spasms, where it's just really hard to know if these spells are where they come from without an EEG.
Right. Okay. So while most seizures fit fairly clearly into one of the seizure type categories we've discussed, some seizures may feature very uncommon or unusual symptoms that don't match the textbook descriptions. Can you give a few examples of epileptic seizures that you've seen or heard about that could easily have been misdiagnosed as being non-epileptic seizures or something else because of their atypical symptoms?
Mm-hmm. Well, I think we talked a little bit already that kind of frontal seizures can sometimes be that because they have a lot of big movements, a lot of, kind of real quick, suddenly out of nowhere, there's shouting and moving, and then they go away real quick and people are back to normal fairly quickly. The other one that I like a lot that I unfortunately don't have in my practice, but those are the reflex seizures. So there are seizures that can be triggered by specific things that, if you tell people that they had it, it's really hard to believe. The example that I've read a case about is that a specific song by a specific artist. And so, for example, the patient could listen to the song by someone else and not have a seizure, but the song by a specific artist would cause the seizure. So I think those are the most interesting ones to me that don't really fit in this classification. The reflex ones where certain stimulus causes a seizure, and it's always the same specific stimulus.
Right, right. And then you have like gelastic seizures, which I guess would fall under emotional, because there's emotional focal aware seizures because there's laughing involved, but that seems like another unusual one that wouldn't fit clearly into some of these symptoms. Yeah,
I was trying to remember because I was thinking about gelastic ones. I think they do put it, I can't remember if it's emotional or not, I'd have to look, but they do, it is definitely one that you have to think through, where would that fit in? And those that we know where they come from, and so we know they're focal, but then really where does it fit in this category, it's hard to say.
Okay. So we talked briefly about post-ictal symptoms, but I wanted to touch back on that. So it's important to recognize and manage the seizures, but it's also important to recognize and know how to respond to possible post-ictal symptoms. So what are some of the more serious post-ictal symptoms that people should be aware of? And then what types of seizures would feature such symptoms, and then how would you respond to these different symptoms as a caregiver?
Yeah, so lots of post-ictal symptoms can be something that are concerning to the caregivers, and so especially drowsiness or real deep, difficult breathing, those can be concerning. But there's also kind of more active post-ictal symptoms such as psychosis, being confused or hallucinating, severe anger and personality changes, confusion. And sometimes that confusion can result in, the patient, I think the real common one is when someone says, well, the emergency, the EMT came, the technicians came, and he was real combative and said he wasn't going to go with them and fought them, and it took all these guys to get him to come into the hospital, and what do I do when I see that at home? Then headaches can be real severe. People can actually have weakness afterwards, so after a focal seizure, there can be what's called Todd's paralysis or paresis, which the arm that was shaking first doesn't move as well anymore. Patients can also get depressed, and the depression in a post-ictal depression can be a couple days afterwards even. So it's not always just immediately after the seizure where things can happen. The confusion can last a while too. And I think as far as caregivers go, it's some of it is kind of just learning what typical is, and if you're comfortable managing it, getting a management plan with your neurologist and your epileptologist. But just also knowing the comfort level. So if a patient's real drowsy and having a hard time breathing and you can't get them to wake up, well, that's an important thing to call the ambulance for, to make sure that they get seen by somebody. If you know that they're real drowsy and that lasts about 10 minutes and then they get better, then it's okay to wait those 10 minutes. But really, if someone's not getting back to normal and they're not coming out like they normally do, that's when it's important to go into the hospital, because there are types of seizures that aren't covered under this classification because they're not the same, where we can't actually see the outward seizure and they're still having a seizure in the brain, and that can happen after an outward seizure. So it's important. Some of the more drowsy, those kind of seizures, or if any of the post-ictal symptoms last for longer than expected, that's something where it's worth getting an evaluation for.
Right. And in particular with the breathing after a tonic-clonic seizure, if you look at even on, Epilepsy Foundation's first aid guidelines, it says, call 911 if breathing doesn't return to normal after a tonic-clonic seizure, but it doesn't really return to normal. I mean, it's a very deep, labored sort of breathing. So is that important to let patients know that, it's not going to be like, oh, I'm back to my normal, regular breathing pattern immediately after the seizure?
Right. It's going to be more like a sleeping breathing pattern, or it is immediately after. I mean, there was physical activity involved, so there might be even kind of a heavy, kind of a slow sleeping type breathing, but that's a little more heavy to it. And then if they're drowsy, it might be just more of a real deep sleep type of breathing and not totally normal. But I'd say if it really seems like they're having a hard time breathing, if it's very slow, anything like that, then it's important to have a concern about that.
Okay. So I'm not too bothered by the continued use of the term grand mal to describe tonic-clonic seizures, because that's still widely understood, and when people use this term, everyone pretty much knows what they're referring to. The term petit mal, however, is so widely misused to describe basically any seizure other than grand mal or tonic-clonic, and so it's become essentially this other category for seizures and is essentially meaningless. I mean, so there's also a connotation with that term that tonic-clonic seizures are the only type you really need to worry about, and that all other seizures are minor. And grand mal is French for big bad, and petit mal is French for little bad, so it has that connotation with it as well. Are neurologists contributing to the continued use of and misuse of petit mal, or is this term rarely used in the medical community?
So I would say hopefully neurologists aren't contributing too much to it. They may in one way, but I'd say that for sure there are other physicians who still use it, still don't feel comfortable maybe correcting the patients because they haven't learned the new classifications or other classifications. And sometimes it's the end. So there are maybe neurologists who are inadvertently contributing because they're not necessarily explaining to the patient how to better describe it. So they might say in the history, someone says, well, then I have my petit mals. And you say, well, describe those to me. Tell me what those are. And then their note might say, oh, this is a focal motor seizure with retained awareness. But they didn't sit down and explain to the patient that that's what this is and that would be a good thing to call it. So the patient continues to call it the petit mal seizure. So I think that probably inadvertently neurologists are, and for certain other physicians are, that just might not be as comfortable with seizures, might not be as comfortable with the classifications and the different nomenclature. And I completely agree with you that it really doesn't mean anything. When someone says, and then I have my petit mal seizures, I take a deep breath and say, okay, well, let's figure out which ones are your petit mal, what are they like, do you have just one kind of petit mal, do you have more than one kind of petit mal? And the other thing is people sometimes, like you said, they call them my small seizures. And so, no, I didn't have any big seizures. I just had 3 small seizures. Right. And that's similar to I just had 3 auras. Well, they're still all seizures, and I still care about them. And I'd still like you to meet the goal of, no seizures, no side effects, and so we're still working toward taking care of those if we can. If we're not at a point where we're saying, yep, that's the best we can do. So.
Right. Okay. Well, before we open it up for questions, do you have any final thoughts or on this topic or seizure types that you'd like to share?
Well, I think kind of just like I alluded to a little bit, that people often have multiple seizure types, and I think being able to say, I have, or my loved one has, or this person I care for has three main types of seizures, and they have, generalized tonic-clonic seizures, and they have, focal motor seizures, whether or not they have awareness, but they have, focal motor, and kind of knowing that they have different types. And even if you can't name them, but if you can say there's three things I see, this is what I see, and knowing that there are different seizure types, I think that that's kind of important and helpful, important to know when it comes to managing it, and helpful for the neurologist when you're talking to them. And kind of the description that you as the patient and that the caregiver and the loved one gives is really important. And I, as an epileptologist, really appreciate it when the family has thought it through and said, this is what I see. I don't blame the patients when they can't, because as I said at the very beginning, it can be really scary, especially if it's the first couple seizures you've seen. And also it's just there's a lot going on. And so I don't ever blame a patient if they can't describe it, but whenever you have a good description, it really makes a big difference in moving toward getting the accurate diagnosis and the accurate treatment.
Right. And related to that, one other thing I wanted to ask is how common is it for patients to have both focal onset seizures and generalized onset seizures? I know that can happen with severe syndromes like Lennox-Gastaut, but is that something you see in other types of epilepsy as well, where you have both, even EEG evidence of some of their seizures are focal onset and some of their seizures are generalized onset?
It does happen. It's much less frequent outside of kind of the more severe syndromes like Lennox-Gastaut and stuff like that. What's more common is that it might be a focal seizure that very quickly generalizes. Right. So you might not see any clinical sign, but if we saw the EEG, there might be just even less than a second, but there might be a little part where one part of the brain organizes first. And then if we actually had and what we often find on that is that that's because we're doing a scalp EEG. And if we did implantable electrodes, we see that there is one specific part deeper down that we don't see on the scalp EEG that's actually been active for a little while. It's been active longer, for more seconds. That is focal. We just don't see outwardly, or we don't see on the scalp EEG as well, and then generalizes, so that it's just a rapid generalization.
Right. And I suppose it's theoretically possible that someone could have a idiopathic generalized epilepsy in childhood, and then later in life they have a traumatic brain injury or stroke or something else that causes focal damage, and therefore they have two separate types of epilepsy in one brain, essentially.
Exactly. Yep, that is possible.
Okay. All right, so we're going to go ahead and open it up for questions. And again, I want to remind people, if you're not asking a question, please do keep your phone muted, either by using the mute feature on your phone or by dialing *6.
I have a question.
Go ahead.
Can you have a tonic seizure, not a tonic-clonic seizure?
Yeah, so as we mentioned, there are lots of different kind of variations of that. So there can be clonic seizures that then have, there are variations of all of those. So you can have clonic seizure that starts out and then goes into a tightening, and then often those go back into a little bit of clonic activity afterwards. So there can definitely be that.
Okay. Another question I have is, I've never thought of the focal part of it. My daughter's 17, and she does the head turn. Like we always say, it looks like she's looking for a bird in the sky. Mm-hmm. And then she goes into what would be a clonic, tonic-clonic phase, I guess. But that doesn't always have to be a start of a focal. That could still just be part of her clonic-tonic episode.
Right, so that may be kind of what we call a localizing feature, so that may help us tell where the seizure starts. So it might say that her seizure starts in a focal area and then goes generalized.
Okay. Mm-hmm. That's something I learned this time. Is that's what I think is happening with her. So that's great. Thank you.
Thank you.
Other questions?
Yeah, I have a question.
Okay, go ahead.
My name's Christine, and I'm asking about my son. He's 18, and he has been diagnosed with focal. Well, it was complex partial seizures when he was first diagnosed. So, but what he experiences now, primarily, and the neurologist is actually questioning if they are indeed seizures or if they're more of like an anxiety attack. But what he's experiencing is, he calls them like brain zaps, or he feels like his brain is kind of shaking, or like if an electrical current is going through his brain, and he calls it like it feels like it's buzzing. Do you have any comment about that?
So, I mean, my biggest comment would be in someone who has a diagnosis of epilepsy and then has a new, stereotypic repetitive spell. He gets these brain zaps that come and go and that are always the same, would be that kind of getting to an epilepsy monitoring unit and trying to capture one of these brain zaps if they're happening frequently enough. Obviously, if he has these twice a year, then it's harder to say. But, I mean, the kind of possible diagnoses these are little seizures that are happening. They are anxiety attacks that are happening. They're related to headache, and they're not related to seizure. So I think getting that accurate diagnosis is the next step.
To add to that, I just wanted to say, too, another key distinguishing factor between seizures and other things is, again, seizures tend to be brief, and particularly focal aware seizures. This is something he's experiencing and is aware during the seizure and has a memory of, then a focal aware seizure is likely only going to last for less than a minute. So if he's describing these brain zaps as lasting for more than a minute, then that would be less likely to be a focal aware seizure. And if it's less than a minute, then it could be. Is that right, Dr. Austin?
Yep, exactly.
Yeah. Okay.
Okay, yeah, and since many of them are more than 1 minute, maybe we are looking into the anxiety attack more kind of a thing?
Yep, you could look at anxiety, or you could also look, like I said, at a headache syndrome, like it could be related to headaches.
Okay, very good. Thank you.
Okay, other questions?
Okay, two Fridays ago, I was having seizures all day, and finally when they dialed 911, I finally had I think they called it an aura, where I tasted metal very heavily, and when the ambulance got there, my heart stopped beating 3 times for 15 seconds on the way to the hospital. So what's the name of those, and is there anything different I can do to stop those?
So I would say it's hard to know. I mean, so it would be a longer conversation that we need to have, because you said you were having seizures all day and then you had that metal taste in your mouth. But you can have a lot of, especially if you were having lots of seizures all day, there are lots of changes that can happen with breathing and heart rate that are related post-ictally, too, to after the seizure. And so that may be more related to having after the seizure, that you were having dysfunction with your heart rate. That's why it's important, if someone has more than 2 seizures in a day, when that's not typical for them, when it's not something that everyone already has a plan for, that you go into the hospital to make sure that we prevent that from happening. Does that answer your question?
Yes, thank you.
Okay, and someone else had a question?
Yes, I did. Sorry.
Go ahead.
When you're speaking with an epileptologist or neurologist, if there was some kind of checklist, but the nomenclature is difficult.
I completely agree, and that's actually why they have the new classification. And that's the hard part is that there have been several different suggestions of nomenclature and a previous classification, so that the old terms are floating around with the new, like Russ talked about at the beginning. But that's why they have the new classification, to simplify things. So if I tell you have a focal onset seizure with retained awareness, then that makes sense to you much more.
It does, but still, at the same time, it's still, it's still difficult to itemize that, compartmentalize that.
Yeah, for sure.
Well, one thing.
And that's where kind of talking with your doctor about getting, helping you understand it can be helpful too.
Yeah, just to let you know too, there is actually a document that comes with the new seizure classification that does have it translates basically, here's the old term, here's the new term. That means the same thing, and it has a glossary of terms as well. What does clonic mean? What does tonic mean? What does atonic mean? All of these things. So that, you can have that in writing, and I'd be happy to provide that to anyone who wants it.
My other question was, how do you guys spell the word for like 2 or 3 days later when you're feeling depression or something after you have had some sort like major to minor seizure?
Post-ictal?
How do you guys spell that?
Are you talking about post-ictal?
So are you talking about after a seizure that you get depressed a few days later still and aren't feeling right?
For sure.
Yeah, so that's a pretty common post-ictal symptom, and it's something to be aware of. And if it's consistent, especially if you have uncontrolled seizures, it's something to work with your neurologist about, because treating depression and epilepsy in general, and even post-ictal depression, is an important thing to do. And so making sure that
even the drowsiness or like feeling weak or anything about it. It's ictal, or how do you spell that?
So ictal is the fancy word for just the event. So it's ICTAL, and that's just a fancy word for the event. So oftentimes the seizure is described as the event or the ictal period. And so post-ictal just means after the event. And that drowsy, that hard time thinking, that can last for a while, is just after the event. And unfortunately, there's not a lot we can do for that drowsiness, the hard time thinking. Mostly just making sure you eat and drink well and you get regular sleep and you are healthy to yourself. But some of that just is a time for the brain to recover.
And Dr. Austin, just in terms of your clinical experience with post-ictal periods, what would you say would be the range of how long that post-ictal period can last? Like, what's the longest?
Yes, I would say sometimes it can be as short as 20 minutes, and then I have patients that say they don't feel 100% back to normal for even, as long as a week or two. Usually the week or two is definitely the outlier, and that's usually kind of just a more vague, not quite normal feeling. And I would say, more commonly is an hour to a day or two,
Right. Is there anyone else who hasn't had a chance to ask a question? All right, I guess we will wrap it up then. So thank you everyone for your participation this evening. And like I said, I do have additional materials because it's a lot to try and remember all of this. So I have there's the National Epilepsy Foundation, epilepsy.com has a web page on this. There's also more in-depth information with that glossary and kind of a translation between the older terms and the newer terms that I can provide to anyone who's interested. So just email me or give me a call if you'd like that. Again, with any questions related to this topic, please feel free to give us a call at 1-800-377-6226 or visit our website at epilepsymichigan.org. So, Dr. Austin, thank you so much for a very thorough and interesting discussion on seizure types.
Thanks, everyone who's listening.
Thanks, Doc.
Thank you.
Thanks.
Thank you.